All right, welcome. If you're studying for your anesthesia exams, you know how critical this topic is. We're going to break down everything you need to know about managing a shared airway during endoscopic ENT surgery, all based on a really fantastic review article. Let's get into it. And this quote right here, it just perfectly sums up the entire challenge, doesn't it? It's the core of the problem. You, the anesthetist, and the surgeon are literally working in the exact same tiny bit of anatomy. It means communication isn't just a good idea, it's absolutely everything. So here's our game plan for today. We'll start by really nailing down that shared airway challenge. Then we'll walk through pre-op planning, all the different techniques in your toolkit, and then get into the really high-stakes stuff like laser surgery. We'll finish up with emergence and the most important takeaways for your exams and your practice. Okay, let's dive right into section 1. What exactly is this problem we're trying to solve when we talk about endoscopic ENT surgery? First off, what are we even talking about? This isn't just one single procedure. It's a massive range of things. It could be a simple diagnostic look-see with a panendoscopy, or it could be a major resection of a big obstructing tumor. Your anesthetic plan has to be completely customized for every single case. So what this really boils down to is a high-stakes balancing act that you're performing every single second. On one hand, you've got your absolute non-negotiables. Keep the patient oxygenated, get rid of CO2, make sure they're deep enough. But on the other hand, you have to give the surgeon the best possible access. And you have to do all of that while already planning for a super smooth, safe wake-up. It's an incredibly delicate balance. So how do you manage that balancing act? Well, it starts right here, way before the patient even enters the operating room. A really thorough pre-op assessment is not optional. This is where you find the potential landmines and figure out how to win before the game has even started. You have to be a bit of a clinical detective here. A hoarse voice? That's not just a symptom. It's a huge clue pointing you towards vocal cord issues. Stridor? That's a massive red flag for a serious obstruction. And yeah, a CT scan gives you a nice static picture, but a nasendoscopy, that gives you the live, dynamic video you need to build a really solid plan. Okay, now for the practical stuff. What tools and techniques do you actually have to manage this shared airway? Let's open up the toolkit. The workhorse for a lot of these cases is the microlaryngoscopy tube, or MLT. They're designed to be skinny and long, which is awesome for giving the surgeon a better view, but that design comes with a pretty major trade-off. And here's where the physics gets really interesting. If you have the radius of that tube, say going from an 8.0 down to a 4.0, you increase the resistance to gas flow by a factor of 16. That's Poiseuille's law hitting you right in the face. What that means in practice is that you almost always have to use positive pressure ventilation because there's just no way the patient can breathe spontaneously against that much resistance. Now, your choice of how you keep the patient asleep is directly linked to your airway technique. If you're going for a tubeless approach, like jet ventilation, you can't deliver gas, right? So total intravenous anesthesia, or TIVA, is your only move. If you've got a tube in, then sure, you can use a volatile agent like sevoflurane. But for a truly tubeless surgical field, we can turn to jet ventilation. This is often done through a special catheter, like this one here. This laser jet catheter goes through the vocal cords, and you can see it has two lumens. One delivers that high-pressure jet of oxygen, and the second one is crucial. It's for monitoring airway pressure so you can hopefully avoid barotrauma. And this table just breaks down the 3 main ways you can deliver jet ventilation. The choice really depends on what the surgeon needs and the patient's anatomy. Supraglottic is great for a lot of laryngeal surgery, but subglottic and transtracheal techniques give an even clearer view by keeping all your gear completely below the cords. Each one has its own risks and benefits that you have to talk through with the surgeon. And remember, the surgeon's choice of laryngoscope directly affects your plan. A wider scope, like the Dedo on the left, gives him a great view and leaves plenty of room for instruments and maybe a jet ventilation attachment. But if they need that super narrow anterior commissure scope on the right, well, space suddenly becomes a huge issue and you have to be in constant communication. Okay, let's really raise the stakes now. Things get a whole lot more complicated when the surgeon brings in a laser, because now you're dealing with the terrifying, catastrophic risk of an airway fire. You've seen this concept before, but it is never more important than it is right here. To start a fire, you need 3 things. The ignition source, that's the laser. You need fuel. That could be a PVC tube, drapes, even tissue. And you need an oxidizer. That's the oxygen-rich gas mix we're providing. To stop a fire, you have to take away at least one piece of that triad. So these are your primary strategies to prevent that fire.
First, get that inspired oxygen as low as you safely can. Use a specially designed laser-resistant tube. Fill the cuff with saline, not air. That way, if it gets hit, it quenches the fire instead of feeding it. And a great tip is to add some methylene blue to the saline so you get an instant blue flash in the airway if the cuff is breached. Or even better, just get the fuel out of there entirely by using a tubeless technique. Now we get to a part of the case that needs just as much thought as the induction: waking the patient up and dealing with complications. Remember, the surgery itself might have changed the airway, creating swelling that wasn't there before. A safe emergence needs a clear plan, but this is also where you have to be ready for the worst-case scenario. And in this setting, there is nothing worse than an airway fire.
If the worst happens, you need to have this drill burned into your brain. You have to be calm and you have to be decisive. You declare the emergency, stop the surgery, stop the gases, pull the tube, and flood the field with saline. Once the fire's out, the work begins again. You have to reassess and secure that airway, fully expecting to see significant thermal injury. These 6 steps are absolute must-knows for your exams.
So, after all of that, all the technical details, the jet ventilators, the laser tubes, the fire drills, what is the single most important thing you need to take away from all this? It really all comes down to this. Your most important piece of safety equipment isn't a gadget. It's clear, constant, and calm communication between you and the surgeon. Having a shared plan, shared goals, and a shared understanding of the risks is what will get your patient through safely. All of the information we've gone over today comes from this fantastic 2023 article in Anesthesia and Intensive Care Medicine. It's a really great resource if you want to go even deeper on this topic.
And we'll leave you with this last thought to take into your own practice. Teamwork is key, we all know that. But what's the one question you're going to ask your surgeon before your next shared airway case to really open up that critical conversation and make sure you're truly sharing a plan, not just sharing an airway?